You are re-engaging the advocates, and I'm assuming that you have heard or will heard, as have I, with regard to this ongoing question about how you prioritize the CalHERS fixes. Mm-hmm. And this notion of income counting and immigration status determination, and how we seem to be putting the cart before the horse with regard to the newly qualified immigrants. So can you respond to that? Because there really does seem to be some growing concern that those two core function issues haven't been addressed first.
So with respect to the immigration changes, those will be happening at the same time in terms, so sort of all immigration CRs are essentially the two, right? There's two happening with the release that would implement this. And then also on the income, it's either that same release or earlier release.
No, the income changes there's some income changes that will occur, but then it had been referenced earlier about a mega income, and that is going to be planned for the 2017 releases.
So, I mean, I think generally with prioritization, I think it's those things that need to be done and also those things that have to be done. As I mentioned, this has been delayed. We were actually supposed to do this in 2015 and then 2016, and the reason we didn't do that was for these reasons. And so, we are tasked with doing this. It's obviously a part of what the legislature and the governor tasked us with in approving the legislation. And so, given what other changes were happening at the same time, it made sense to put them in with the other immigration changes.
Thank you. Elio, Finance. Let's move on to public comment. 2 minutes, please.
Linda Way with Western Center on Law and Poverty. We too share the concern that CalHERS programming, particularly around notices, is happening before key decisions are being made. We still have many problems transitioning people from Medi-Cal to covered California and vice versa. So setting up another program that moves people between systems is troubling, especially when advocates are just now starting to be re-engaged in the process. We do appreciate that these calls have been set up, but would like to note that we were given 1 day to comment on one particular notices that had some key policy concerns. And we'd also like to echo the chairwoman's concern that these changes are occurring, are being prioritized before other problems have been fixed. And so would like to know what the rush is in terms of that this is happening at a very quick pace, and so without these key policy decisions being made.
Kimberly Chen with the California Pan-Ethnic Health Network. Just want to echo the comments of my colleague. Thank you.
Tam Ma with Health Access California, and ditto.
Yeah, Kevin Aslan, Coalition of California Welfare Rights Organizations. I speak several languages, and I have a lot of people who have refugees or immigrants who call me up with these problems, and I could see a lot of problems once this goes into effect. Often these things go into effect simply with English language information going out. And then later on, they translate them. And I think there should be some control language saying that you cannot start this process unless all language notices are ready to roll before this goes into effect. Otherwise, it's going to be chaos out there. Thank you.
Thank you for the conversation with regard to the prioritization, because that is an issue that we've had with OSI, questions that we've had with OSI, and we can continue to raise as we hear inquiries from both constituents and the advocates community. So thank you. We're going to leave this item open. We're going to proceed on to issue 7, Dental Cal oversight.
Sure. So first, the actual proposal on the table is another budget change proposal, and really this is in response to the additional workload that the department has taken on in response to the concerns raised about the dental program as well as the CSA audit. And so in order to thoroughly address those issues and continue to work to improve the program, we are requesting 4 permanent positions and associated expenditure authority. These positions will be focusing on beneficiary services, provider services, as well as additional resources for our data analytics team to continue to make sure we provide those timely reports to you on all of the utilization and benchmarks that we are committed to provide. In response to the questions, in terms of our update on the corrective actions. So we are in the process or have implemented, process on 8, have implemented 15 of the 23 recommendations that we are implementing. Some examples of what we've done: we have established the beneficiary and provider participation metrics for better assessing access to care and utilization. We have reinstituted the annual rate studies. We've worked with Delta to establish their annual outreach plans, particularly in the underserved areas, as well as develop alternative access points such as the mobile clinics. And we continue to evaluate administrative simplifications given the concerns that have been raised by providers, and that does include last year removing a requirement for x-rays for certain services, and so we'll continue to evaluate those types of changes. In terms of the utilization changes, as noted in the agenda, we are continuing to analyze the changes in utilization for both children and adults, and really are looking to take a more comprehensive look over the last couple of years to, you can never really point to one thing. A lot of things have changed in the last couple of years, and actually we'll have more changes with the implementation of the Dental Transformation Initiative. So we're wanting to assess what's happening. We have caseload changing, we have the adult restoration, we did have the 10% restoration as well, and then we'll have the DTI coming in. And so the initial data, as noted in the agenda, does show in the initial months after the restoration a fairly significant increase in the claims for children. And so that increase, is good to see. What we haven't seen yet, and this is why I've asked the team to look in more detail, we haven't seen that translate into some of the metrics changing. So we haven't seen a change in the annual dental visit metric. So even though a lot more services were provided, it's not clear that they were actually provided to more people. They could have just been provided to the same, which isn't a bad thing, but it's trying to just really understand in more detail what's going on.
Generally.
So we also haven't at this point, and again, a lot of things are happening on the provider side because of ACA and revalidation, but we haven't seen any significant change one way or the other in provider participation that we've noted. So we're going to continue to look at this and really try to peel back what's happening, why is it happening, and be in a better place to then also assess the impacts of new things, including, very importantly, the Dental Transformation Initiative, because our hope is that that waiver program will have significant impacts on the utilization, and we want to be able to assess that sort of separate from these other things that are happening. The next question was about Delta's performance on the outreach plan. So we are looking to have a comprehensive report for 2015 in the next month or so, but some examples that we can provide: they have done numerous things. They visited many health fairs and schools where they've provided educational information as well as handed out things like toothbrushes and toothpaste. They've also visited county and community agencies, again, to provide information, make sure they're able to tell people what are the benefits available, how do you access them, as well as, again, just basic oral health education. They've also done workshops in various counties, provided training to our safety net clinics, as well as visited school-based health centers, again, to provide information both about the program and how to access services, as well as how, important oral health educational information. Delta did provide their outreach plan for 2016 in December. It's currently being updated to account for the waiver initiatives, and so we are expecting their first quarterly report in April for 2016. And then finally, getting to the actual waiver program, it is, as I mentioned earlier, something we're very excited about. It's a major initiative in the dental program. It's a lot of money and a lot of effort to really target on particularly pediatric dental services. The entire initiative is about pediatric dental. There are 4 components. The first is focused on improving the use of preventive services. So having children, looking to incentivize providers to make sure children are getting those preventive services to prevent obviously more costly and invasive and painful procedures later on. The second will be testing a risk assessment and treatment model in pilot counties. The third is aimed at increasing continuity of care for children and their dental providers, so rewarding dentists who are actually serving as a dental home where the child is coming back year after year to that provider. And then finally, there will be an opportunity for communities to propose local dental pilot programs to test different efforts aimed at improving dental pediatric care. So, really, the focus here is how do we test these different things in terms of a value-based payment method by really having these incentive payments available for things like preventive services and continuity of care. Obviously, an investment of $750 million is not insignificant. And all of that, again, will be going to providers. And so our goal with all of this is to improve the oral health care for children, to achieve our overall statewide goal of increasing the utilization for children by 10 percentage points, and really focusing, again, on prevention and initial oral health. So, again, we're hopefully preventing sort of more invasive and costly procedures later on.
I couldn't agree with you more that this is a really unique opportunity for California to really be transformative in terms of improving oral health for kids. We heard from our new state dental director last week, I believe, in this committee. I knew of him based on his work in New York and the amazing strides they were able to make in terms of improving oral health, particularly for poor kids. So I'm really hoping, I know we all live in silos and you all certainly work in silos, but I'm really hoping that you can include, particularly given this unique opportunity with this waiver, that he can be included in that work, given his history, given his vision and charge as the state's new dental director, and he can be included in an ongoing, meaningful way in terms of executing this new initiative. I think it would only bode well for both your department as well as his. So I'd strongly encourage that. We offered our help and our willingness to partner, so I hope that you all will be willing to do that as well.
Yes, we absolutely already are. This is under Renee's purview, and she's already working and making sure that he's included in this work, because obviously we want that expertise.
Excellent. We know that was he a part of the Medi-Cal Children's Health Advisory Panel yesterday? If not, invite him next time. He's new to California, just invite him.
We will absolutely invite him.
Thank you. I appreciate it. We have to be nice to our new Californians so they won't leave. Senator Monning.
Thank you. Certainly the increased funding is encouraging. There's a chart on page 47 that identifies certain counties that are below standard or far below standard. I see 3 of the counties I represent are below standard. It seems like the focus here is on the lack of available dental services. What steps are you taking to try to, I mean, you've obviously highlighted these counties. What are the next steps to, it sounds like recruitment and retaining. Is it to get dentists to accept the Medi-Cal payment? And is that a problem, the amount of reimbursement?
So I think, it's a combination of in some of these places, not a lot of dentists at all. So that's part of the challenge, and where we're trying to think of what are some alternative access alternative modalities, whether it's telehealth or other things that we can use where there aren't actual dental providers. And then certainly, there are providers who are unwilling to take Medi-Cal, whether it's a rate issue or others. We also have providers who just don't want to see Medi-Cal patients. But yeah, so the goal, with Delta, we're working on what kinds of outreach efforts can they do, educational efforts to do this provider sort of recruitment and then retention. And then some of the elements of the waiver initiatives are actually going to focus on these underserved counties initially first, in terms of the additional funding with the incentive payments and such, because we recognize, again, the need to target some of that and really focus on areas where we know our kids are having the hardest time getting services.
Thank you. Thank you, Madam Chair.
What have you done to help with enrollment in the Dental Cal program? Will there be anything under this initiative, or have you done anything just to make it easier for dentists to manage administratively?
Yeah, so we are looking at ways we can improve the enrollment process, and certainly working through that. We recognize that there are some elements of our provider enrollment for dental that essentially it's the same process as it is for all of our providers, and there are things that aren't necessary for the dental program, so we are looking to see what we can do there. And then other administrative simplifications in terms of, as I mentioned earlier, some of the billing changes and treatment authorization requests. We have made some improvements, but are continuing to look at where else we can do simplifications so that it makes it easier for them to participate.
That's helpful, thank you. Finance, LAO. Public comment, please. 2 minutes.
Good afternoon, Brianne Pittman with the California Dental Association. Just want to say that we appreciate the responsiveness of the department in addressing the issues that were raised in the state audit. We were able to provide the department some feedback on the 2015 outreach plan, and happy to continue doing so as that's necessary or helpful. I think that we remain concerned that there are these counties that simply don't have providers or don't have providers who are interested in taking Denti-Cal patients, and know that trying to entice these providers without looking at the reimbursement rates or the administrative burden that the providers face may not be enough to bring them in. So appreciate the work that the department is doing on addressing those, the enrollment and the administrative barriers. On the rate reversal and the utilization increase, I'm glad to hear that the department is looking more into these numbers, because I had some of the same questions. You see this big jump from June to July. There's not anything on the chart that shows July and August 2014 to compare. And if you look at October 2014 to 15, the adult utilization has actually gone down. And so sort of better understanding what those mean. I think we were very happy that the legislature recognized the significant access crisis last year and did that 10% rate reversal, but we know that we have a lot more to go before we really, are kind of where we need to be. So we'll just say that we support the budget change proposal to allow this department to continue doing the good work on addressing the issues raised in the audit and the DTI waiver, and we'll continue to look forward to working with them.
With regard, before you leave, with regard to the chart on page 47 that really looks at extremely below standard, barely below standard, in terms of Delta dental dentists, do these counties overlap based on CDA's experience with just a low dentist to general or high dentist to general population ratio generally? I mean, are these counties that we just have, don't have enough dental professionals, period?
I think that a number of these counties are rural counties where there just aren't as many providers in general. Some of them may, I think, are places where there may be dentists who just don't take Denti-Cal. I just was looking over this recently.
Okay.
I think we'd probably need to dig into that a little bit more.
That would be helpful, I think, just for us to get a sense of where that overlap happens. Thank you. Next witness, please.
Linda Way with Western Center on Law and Poverty. We do appreciate the department's effort to address the low pediatric utilization rate. I would also note the need to fully restore all adult dental benefits. We do appreciate that the legislature did partially restore adult dental, but we continue to hear from our legal aid advocates that this continues to be a huge issue. Thanks.
Thank you. Next witness.
Tim Lynch on behalf of Liberty Dental, one of the state's contracted managed care companies in Sacramento and Los Angeles County. We appreciate all the hard work that the department has done, the improvements that have been made, and we look forward to the opportunity to work on the waiver and have some creative solutions moving forward.
Thank you. Next witness.
Kathy Dressler with the Children's Partnership, also very appreciative of the work that the department has done to incredibly increase the rates of utilization for kids. Look forward to working with you on the Dental Transformation Initiative and seeing that projection keep happening. Thanks.
Next witness, please.
Tam Ma with Health Access. Like to align myself with Kathy Dressler and with Lyndon Way and whatever she says behind me.
Next witness. Okay, say something that, come on now.
Tam hates dogs. There we go. I'm just kidding. Kimberly Chen with the California Pan-Ethnic Health Network. Echo the comments of my colleague from Western Center, but would also like to note that when we're talking about the lack of providers across, Denti-Cal, I really want to note how that impacts individuals who have specific linguistic needs or folks, providers who can provide culturally appropriate care, and how that goes down even more in talking to our members across the state. In Southern California, one provider from the Southeast Asian community who served a lot of folks when he was one of the few Denti-Cal providers in the area. So when he retired, the whole community stopped going to see the dentist.
Right.
And for those who needed Denti-Cal, they just didn't trust anyone else in the area. So just to highlight that when it comes to the provider shortages for folks who have specific linguistic needs or folks who need culturally appropriate care, it magnifies So thank you.
Agreed. Thank you very much. We're going to hold this item open. We'll move on to issue number 8, AB 85, health realignment.
Sure. So the particular request in front of you is for 3 equivalent to 6 positions, 3 of which are continuing work and 3 of which are new, and then 1 permanent position which is converted from an existing limited term. These are positions that will enable us to do the AB 85 realignment calculations that went along with the ACA expansion, as well as some of the audit work related to both that and just our public hospital financing generally. In terms of the question with how long it will take us to work through the prior year audits that are still pending, we're estimating that it will, with these resources, if we were to get them, that it would take us about 3 years to work through the 6 years of prior year audits that we need to accomplish. That would mean 2 a year. And we think that's probably the most that could be done even from a hospital perspective, because they actually have work to do when we do audits of them, and so we think that's a appropriate time frame. And then with respect to CMS, I mean, certainly they both understand the challenges that we're facing. It's a very complicated audit structure, but they also want to see progress. And so we are working with them, and so the reason we didn't specify which years would be done at which time is because we're working to figure out what's the right order. Do we do the most recent ones first and then go back, or are there other orders that would make sense? So we'll be working with them and with the hospitals on the best way to accomplish this over the next 3 years.
Page 54?
Yes, I did this. That's fine.
I heard you. All right, LAO, finance. Any public comment on issue 8? We'll hold this item open. Thank you. We'll move on to issue 9, FQHC's pilots, SB 147.
Sure. So we are requesting 3-year limited term funding equivalent to 2 positions in order to implement the pilots that were authorized under SB 147, which really allows us to implement an alternative payment methodology for interested federally qualified health centers. Currently, the reimbursement is a sort of a fee-for-service based on cost and has particular billing requirements. And so what this would do is would convert that to a capitated payment. So it would be sort of a risk-based payment, still equivalent to their PPS rates. But then it would also provide them the flexibility to actually provide care in the way that makes the most sense for the beneficiary, instead of having to deal with some of the more restrictive rules that govern FQHC. So that would mean being able to do multiple visits in a day. It would also mean being able to do things that aren't billable today, like group visits for diabetes case management and things of that nature. So we're very excited about the pilot, and the proposal for the positions is to let us move forward with that. In terms of the interested clinics, at this point, we don't have the official list because partly we're asking for positions to actually implement the process, but we are trying to work through at least the application process and the criteria that would be used so that we can be ready to go forward with that. We have been engaged over the last 2 years with the clinics and plans on this issue. So during that time, we've gotten various lists, and in the past, what we've seen is about 65 or so clinic sites that are interested in 16 counties. So that's about 15 health plans that could be impacted.
So they know it's coming?
Yes.
Won't be a surprise?
No.
Got it. Finance, LAO. Any general public comment on this item? Seeing none, we'll hold it open. Thank you. Issue 10, health homes activities.
Sure. So we are requesting 3-year limited term funding equivalent to 6 positions in contract funding to implement the health homes program that I know you are well aware of what that is.
I vaguely
to enable us to take advantage of the federal opportunity that includes enhanced federal funding for some of our most vulnerable beneficiaries. In terms of why it's taken us this long to get there, We've had a few things going on in the last few years that have taken a lot of our effort, and we just simply didn't have the capacity to do this sooner with all of the expansion as well as managed care and CCI and new benefits and the development of the waiver. We wanted to make sure that we did this in a thoughtful way that involved stakeholder input in the structure of the Health Homes program. And so we've done that with a stakeholder process that began at the end of 2014. And that's really informed the various versions of the paper that lays out the concept for Health Homes that we did finalize at the end of last year. And so we are now in the process of about to submit the state plan and are looking for a start in January of next year.
Great. LAO or Finance? Public comment, please.
Linda Way with Western Center on Law and Poverty. We appreciate working with Senator Mitchell on the bill to create the Health Home program. This is, but also express concerns relating to the delay in implementation. It's a critical program that should be implemented immediately. It also works in conjunction with the Whole Health program, whole person pilot care of the waiver. Thank you.
Agreed. Next witness.
Tamma with Health Access. We supported the underlying legislation as well as the creation of the home health or the Health Home account last year, and we support this BCP to get this going. Thank you.
Thank you. We're going to hold that item open as well. Thank you very much. Moving on to issue number 11, the Medi-Cal electronic health record staffing.
We are requesting 3-year limited term resources to continue implementation of the Medi-Cal EHR program. And these positions are to provide technical support, perform research, evaluations, assessments, audits, reviews, coordination, and define any barriers and eliminate and reduce them. With regards to the recent federal guidance that we just received, which now will allow high-tech funds to support and facilitate the health information exchange with behavioral health providers, long-term care providers, substance abuse treatment providers, home health, social workers, correctional health, laboratory, pharmacy, public health, and so on. So our plan in terms of implementing is making sure that we're holding and reaching out to numerous stakeholders. You know, some of the groups that we plan to engage in conversation regarding some of these initiatives include the California Association of Health Information Exchanges, healthcare associations, but we'll be working also closely with departments and offices within the California Health and Human Services family to assess opportunities to leverage this funding.
LAO or Finance, any questions or comments? Any public comment? Seeing none, thank you for that update, and we will hold this item open as well. Issue 12, Health Insurance Portability and Accountability Act Compliance and Monitoring.
We are requesting positions, 8 PYs, from limited term to permanent, and to continue efforts to maintain compliance and address new HIPAA rules, provide support of CAPMAN, which is our capitated payment system, and continue to provide oversight of privacy and security. With regards to the next question, does the department have sufficient resources in terms of HIPAA review of Public Records Act request? We have established a process, de-identification. I have with me today our Deputy Director for the Information Management Division who oversees, the data releases. These positions specifically are related to supporting the implementation of HIPAA laws and regulations, and so they're not specific to the PRA's Public Records Act. We do have positions distributed throughout the department to assist us with a Public Records Act request. But in terms of, are there delays experienced with HIPAA, in terms of the de-identification of those releases? The answer is no, that we aren't experiencing delays with the de-identification. We may have some delays related to just the data request due to the complexity or perhaps the broad nature of some of those requests. So making sure that we're bringing on the requester early on to make sure that we gain a full understanding of the specific request so that we can make sure that we're doing the data pools to meet the expectations.
And so do you have a backlog? as a result?
So I'll have to look into that, but I will tell you that we do work with our requesters on a regular basis. We are mandated, to provide data within 10 days, and if we're not able to meet that, we can grant an extension, but the extension is also for us to respond. Sometimes it takes us longer than that. So we are continuously looking at the processes and procedures, but I definitely will need to look at, in terms of the level of backlog, if we do have any.
Thank you for that. Appreciate that. Finance or LAO, any comment? Any public comment on this item? Seeing none, we'll hold it open. We'll transition now to issue 13, third-party liability recovery workload.
So this is to address current staffing levels that are insufficient to address the workload needs in the cases that we have. As a result of the implementation of the Affordable Care Act, the number of incoming case referrals reached nearly 6,000 from about 3,500 caseload. So since we are the payer of last resort, we are required to impose liens on personal injury settlements, and we expect recoveries of about $8 million annually.
Finance or LAO. Any public comment on issue number 13? Seeing none, thank you. We'll hold this item open as well. Issue number 14, elimination of the workers' compensation information sunset. We're talking about trailer bill language, page 66 of the agenda.
Right. So the Social Security Act mandates DHCS to take all reasonable measures to pursue reimbursement of Medi-Cal costs for treatment provided to injured workers where an employer has fiscal liability. So this proposal removes the sunset sunset date provision, which will allow DHCS to use the information from the Department of Industrial Relations as it's the primary source for identifying non-contested workers' comp claim files and unreported workers' comp claims.
Finance or LAO? Any public comment? We will hold this item open as well. Final item for today's hearing, issue 15, supplemental drug rebates, cleanup trailer bill language.
Sure. So until trailer bill was passed in 2014, we were only allowed to collect supplemental rebates on drug utilization in fee-for-service or with our county organized health systems and not with the rest of our Medi-Cal managed care program. So the trailer bill in 2014 extended that ability to allow us to collect utilization from the rest rebates for the utilization in the rest of our plans, but only for drugs where we are paying a separate capitation rate, like we began doing in 2014 for the hepatitis C drugs. The goal was to allow for these rebates to be collected for classes of drugs, and typically those are the high cost drugs that we would be looking at. As we worked to implement this, we did find some technical issues in the trailer bill that prompted us to propose this technical cleanup language. These changes align with the original intent of the bill to allow us to do contracting on a classification basis and not necessarily on specific drugs, as well as there were just really other technical problems with the language, whether it was numbering or inconsistent or omitted language. And so without these corrections, we were concerned that the statute could be misinterpreted and we could put at risk our ability to collect these supplemental rebates.
LAO, finance. Any public comment on the drug rebates cleanup? Seeing none, we will hold this item open as well. Thank you very much for participating in our third sub 3 hearing. Today's hearing will stand adjourned. Thank you all.